Good afternoon. I'm Loretta Hoffner, and I'm the Executive Director of the Maryland chapter of the American Academy of Pediatrics. And it is my pleasure to welcome you to today's webinar. I'm running tech today on myself, so here we go. And that's not the slide I want to be on. All right. Let's try this again. Good afternoon. There we are. All right. So today we're here at webinar 6 of our MDAAP AAP Disaster Preparedness Project on July 5th, 2023. Again, I'd like to welcome you to the 6th webinar in the series of 6 that we're doing on this project, a Pediatric Disaster Preparedness Ambassador Program Chapter Grant, which was funded by the National AP with money from the CDC. And again, this program supports the engagement of pediatric disaster preparedness ambassadors, as well as helping those of you in our MDAAP chapter be equipped to address the needs of your patients regarding disaster preparedness efforts, as well as preparing your staff and your practice. Our team coordinating this project is Dr. Amina Hussein, myself, Loretta Hoffner, and Ariana Kemper, who's the MDAAP Executive Coordinator. There are 3 activities in this disaster preparedness project. This is the 6th, as I said, of a 6-part webinar series. We are going to make our tabletop a virtual one, and we'll address that in another slide or 2 coming up. Activity 2 is a scavenger hunt, which all of you members should have received an email from myself about. That will help you investigate and find resources in your area that will help with disaster planning. And then the 3rd part will be, we'll list all these great resources that you all provide back to us through that SurveyMonkey onto our Disaster Preparedness Committee webpage. All right, again, we're going to change our tabletop exercise to virtual. Amina, do you want to say a couple of things about that real quick?
Yeah, no, we are excited to do this tabletop to help prepare all of you for your disaster planning and improve on your disaster plans, kind of based on the webinar series that you've been listening to. And we decided to go to virtual. It'll be next week. We're looking for the best option between Wednesday, July 12th and the 13th, and it'll be in the evening. I think that this is an exciting opportunity for you to kind of go through your disaster plans. And if you don't have one, that's okay too. We will help you build one. And so it'll be a great workshop for everybody. We'll let you know as soon as we have that date solidified based on kind of what's most available to all of you, and get that registration out to you. And then next, I wanted to introduce, I am so excited to introduce Dr. David Schonfeld. Just a little bit about Dr. Schonfeld. He is just, it's a lot of things, but I'm going to list them all because I just want you to kind of know all of the things that he's done and how amazing he is. So he's a developmental behavioral pediatrician who's completed his residency at CHOP and has done his fellowship at University of Maryland right here in our state. However, now he is a professor of pediatrics at the University of Southern California, Los Angeles Children's Hospital. And in addition to that, he is on a lot of national committees, including the National Advisory Committee on Children in Disasters and on the Executive Committee for the AAP's Council on Children in Disasters. He has been he is a director of the National Center for Child of School Crisis and Bereavement, which he has founded in 2005. He served on the National Biodefense Science Board and the commission for both the National Commission on Children in Disasters and the Sandy Hook Advisory Committee in Connecticut. So a lot of kind of work at some of these very unfortunate events that we've seen in the past. He continues to provide consultation, training, and school crisis and child pediatric bereavement and the aftermath of numerous school crisis and events and disasters, not only in the US, but also internationally. And I think most recently, unless there's been one since we last talked, in Ukraine. So it's really exciting to have you here and really excited for you to give this talk to us on supporting children, families, and after a crisis event. I'm going to hand it over to you, Dr. Schonfeld.
Thank you very much. Well, it's my pleasure to be here. So I first should start by saying I have no disclosures. There's no conflict of interest, and I'm not going to be talking about any medications approved or non-approved. So really what I'm here to talk about is really how do we support children and families in the aftermath of a crisis event. And I do want to say that although I would hope we don't have many large-scale crisis events, and each of you don't have to deal with that. This is relevant for personal and family crisis as well. So you deal with families who are in crisis all the time. Just a diagnosis of serious illness is a family crisis. And so you should be able to use this information as well. So what I wanted to start with is in the immediate aftermath. And I just, you know what, I think my apologies. These are actually the wrong slides. So let me get the right slides up for you. I apologize. I just did a presentation in Massachusetts, and so I think the Massachusetts and the Maryland one, once abbreviated, they look very close to each other. So let me just call.
Which just goes to show how much you are kind of loved for your expertise and everything else across the country.
Yeah, I just did the one last week. It was actually in Massachusetts. So let me hold on one second.
And before, as he's pulling those up, just, before we came on, we were talking, and just to time this lecture, Maryland had its very own unfortunate event this past holiday, where there was a mass shooting at a block party. So if you are watching this slightly removed in the next few days, and you'll understand how important this talk is for where this could have happened at any block party across anywhere in Maryland. And those children could have been children that you see in your own practice. So really good to understand how to manage that.
All right, well, I have the slides, so I'm just going to reshare my screen and we should be good to go. And again, my apologies on that. All right. So as I said, I do not have any disclosures. So that is the next slide. So I wanted to start with psychological first aid. So in the immediate aftermath of a crisis event, psychological first aid should be provided broadly to all those who are impacted. And it really involves offering psychoeducation, helping people understand some of the common reactions and impacts of a crisis event. And most importantly, you're helping them understand how to cope with that. You also are trying to provide supportive services, and the goal is to promote effective and normative coping strategies and adjustment. It is not a treatment. Instead is an approach to accelerate the natural healing process. And all adults should understand the likely reactions and how to help children cope. Because the reality is that anyone that interacts with children and their families after a disaster can be a potential source of assistance and support. But if they're unprepared, they actually can become a source of further distress, particularly if they appear disinterested or not willing to help. So your institution, your practice, your healthcare system will be known by the one insensitive comment that someone makes to someone who's in distress, but it can also be known as the one known by its one sensitive and supportive comment that someone makes when someone is in distress. I had the opportunity to do some training at the Flight 93 Memorial outside Pittsburgh. This was the flight that was rerouted by terrorists on September 11th towards Washington, D.C. But for a number of reasons, the crew and the passengers were able to make some cell phone communications with people on the ground and heard about what had happened at the World Trade Center. And so they collectively tried to overthrow the terrorists on board the plane and ended up crashing their plane outside of Pittsburgh. So there is a national park and a visitor center dedicated to them. And it's really a beautiful site to visit if you have the opportunity. So I did the training for them, and at one point somebody came up to me and he identified himself as someone that was in charge of groundskeeping. And he said that he had trained his staff that if they're cutting the lawn and they see a visitor, they're to stop what they're doing, establish eye contact, and ask if they can be of assistance. And he looked at me and he said, "We're not here for the grass. This is sacred ground. We're here for the visitor experience." Now, part of me felt like saying, well, actually, you are here for the grass as part of the National Park Service, and you are hired to cut the lawn. But the point is that they understood the larger purpose of why they were there. So I would say that if you have a clinic, if you have a hospital, if you're, pediatric department, everyone that works there is there for the patient and family experience. And they need to have that overarching goal to understand their real purpose of what they're there for. And if they work in a school, even if they're there to cut the lawn, they're there for the student experience. So psychological first aid is something you should train everyone to be able to do so that they can be supportive. But for some individuals, the psychological first aid and just providing basic services are not going to be sufficient, especially if they're also coping with additional stressors or if they have limited resources, such as individuals already dealing with racial inequities or poverty. So the second complementary approach involves timely and effective triage and referral in order to identify and deliver services to those children who would benefit from additional mental health care. So one of the first steps in that timely identification involves recognizing the potential symptoms of adjustment reactions, some of which are listed on this slide. Now, I do have to say that the most common symptom is not listed on this slide, and that's nothing. Most individuals, children included, who are under distress will hide their distress. They often feel that it makes them abnormal or it becomes a burden to other adults around them who are visibly upset. So they may actually hold any of their symptoms or discussion of their symptoms. So you do need to refer and or monitor based on risk factors alone. So if a child has been through a crisis event and they had a family member die, for example, or their home was destroyed in a natural disaster, even if they seem to be doing okay, you still want to make sure that you have further inquiry and offer additional support. So let me go over some of the common reactions that occur whether or not you see them. So one is fears. Now, those may be fears related directly to the crisis. If there's been a shooting, they become afraid when there are loud noises. If they were involved in a tornado, they may become fearful when the weather becomes more severe. Those, I think, people anticipate and recognize fairly readily. But there's also anxiety. Individuals may just become more fearful, and those fears may not have to do anything directly with the crisis event that's occurred. So, for example, whenever we've had crisis events of any nature, whether they've been school shootings or even natural disasters that occur on the weekend when the children are home, children are still afraid to return to school. They don't want to separate from those that they care about when they've been through a crisis event, because they may worry that something will happen to them if their parents and other caregivers aren't there to protect them, or they may actually worry that something will happen to their family members if they aren't there to monitor or to help them themselves. So you can expect school avoidance after any crisis event, and it's just one example of the type of anxiety that you may see in children. So one of the things that I try and make sure I communicate to pediatricians is if you have a family that sees you in practice and they ask for a letter of medical necessity for home-based education, you should not be writing that letter. The best and most important component of treatment for school avoidance is to get kids back at school. Now, it may have to be for a very short period of time. They may only be able to sit in the counselor's office for an hour, but you need to gradually return them back to school with the appropriate supports and accommodations, but you don't want them just to stay home. The next adjustment reaction that you'll see on the slide is sleep problems. That can be trouble falling asleep or staying asleep, difficulty waking in the morning, nightmares, or really any disruption in sleep. And if people don't sleep well, they don't function well, at least for a day or a couple days. And you may also see similar types of changes in appetite or eating. It may increase or decrease. Now, these adjustment reactions are not specific to a particular crisis event, and it may actually be difficult to determine precisely what is the cause of that specific adjustment reaction. So let me go back to difficulty sleeping. As I said, it's one of the most common reactions to the crisis, and it may be due to a range of reasons. So I remember in presentations that I was doing in the early part of the pandemic, when kids were mainly staying at home at that point, parents would ask questions like, well, my teenager is up late at night and then he sleeps in the next morning. How do I know if he's just doing that because he's depressed, or he's anxious and is having trouble sleeping and has insomnia, or because he's engaging in risk behaviors and doesn't want me to be aware of it, or he's just a teenager that wants to stay up late. And sometimes it's hard to sort that out. And I think there's a tendency for us to just tell kids, you shouldn't do it because it's not normal. Well, the reality is there was some functional benefit for staying up late at that point. If you could think back, say 5 years ago, if somebody asked you, what would you say to a teenager if you had to tell them that they could not leave their apartment while their parents were there for 10 months? You would just say, I would never, you can't do that. That wouldn't happen. But that's functionally what we were asking some kids to do. So for some kids, staying up very late and sleeping in the next morning allowed you to kind of socially distance when you couldn't physically distance. So in other words, you shift your schedule so that your parents and other caregivers, they go to sleep. And then you've got 3-4 hours where you can stay up, chat with your friends, believe that you are not home anymore and that you're really with your peers. And then you sleep in the next morning, and that gets you a couple more hours of individuation or separation. And so it works at some level, but it doesn't work if you have remote classes the next morning. It doesn't work if you're waking up people while you are awake, or if they're waking you up when they get up in the morning. And so I encourage people, I go through this example because we have to stop looking at, is it normal or abnormal? You have to start looking at the functional implications of it. So what I would say to kids is it's not abnormal to stay up later at night. They'll say, all of my friends are doing it. It's normal for us. But the issue is, if you're not sleeping enough, or you're not able to participate in your homework completion or in your virtual classes, it's not working. So I think in general, when we look at distress, we should be looking at the functional implications of it, as opposed to trying to classify it as normal or abnormal. Now, there will be some situations where kids have depression, suicidality, and those are mental health diagnoses, and we do need to look to diagnose them and also clarify that that isn't within the range of normal. But for most of the adjustment reactions that you're going to see after a crisis, they'll be nearly universal. We should not be focusing simply on whether they're normal or abnormal. Getting back to the list of adjustment reactions, the next one is difficulty with concentration in academic and work performance. One of the things I was saying early on in the pandemic is it isn't just about getting kids back into classrooms, because even after they get back into classrooms, they're still going to have trouble learning. They will be distressed. The teachers will have trouble teaching. I've been with schools that have had mass shootings, and they've opened the school building and resumed classes within a day or within a week. The kids still have difficulty learning. So you can expect problems with concentration and academic and work performance to persist until the crisis is fully resolved. The next is sadness and depression. It's expected the kids would be sad when something tragic happens, but depression is when it becomes clinically significant and requires intervention. And our goal is to discern between the two. Anger or irritability is also common in individuals when they've been through a crisis. So when children are highly stressed, they may regress socially. They'll act less mature, become more demanding or more selfish, or have more difficulty getting along with peers or family members. We see this in adults as well. We often talk about how children are not just little adults. They have their own physiology, they have their own needs, they have their own developmental differences. But part of what I do say is that in a crisis event, adults act like big kids. And part of it is this social regression that occurs. So you should, I tell people, just figure out how to support kids during a crisis. And then you got a pretty good chance of how you're going to support the adults as well, at least from the mental health perspective. Alcohol and other substance use is something which is another reaction, common reaction to crisis events. So substance abuse evaluation and treatment services should be part of the recovery plan of any crisis. This is also the case for adults, including healthcare and mental health professionals. I remember going to New Orleans after Katrina, and during one of my visits several months afterwards, one of the people who was sponsoring and hosting my visit was a mental health provider in the school. And she listened to my presentation, and she told me afterwards that about 2 to 3 weeks after Katrina, She had gotten a text from her daughter one day after school asking where she was. And she said, so I texted back and I told her that not to worry. A number of friends from school were out at happy hour and that we were doing fine. So her daughter just texted her back, you've been at happy hour every day since Katrina, and you don't seem happy at all to me. And she looked at me, she goes, and that's when I realized I was drinking more. And so the issue is that alcohol and other substance use is common among health professionals as well. And I will say, not as a criticism, but I participated in 2 major pediatric conferences within 1 week for 2 different professional organizations at the height of the pandemic when we were still quarantining, and both of them had a virtual happy hour. They encouraged their members to get alcohol and sit on Zoom and socialize with each other. And I thought that's probably not a really good idea for people who are in a very stressful situation. We should not be encouraging the use of alcohol and other substances. Another common symptom is physical symptoms, and that can be headache or stomach ache. And that can be due to psychological distress presenting as physical complaints. We call that somatization, but it can also be from the stress hormones themselves. So we know that stress hormones can precipitate asthma attacks in vulnerable individuals. It can also increase blood pressure, worsen diabetes control. So we will see physical symptoms either purely from stress. So for example, you can have people breathing quickly during the pandemic because they were having panic attacks, but it could also be the physiological impact of the stress hormones. So you could see asthma attacks, and that's why they're breathing quickly. Or it could be that they're breathing quickly because they have COVID. So it really can be a range of things. And so that's our goal, is to try and sort out which among them is causing the individuals difficulties. But we have to recognize that often it is more than one cause at the same time. Now, children may also demonstrate post-traumatic symptoms, and some will meet the criteria for post-traumatic stress disorder. I'm not going to spend any time talking about that, because I think as a society, we've done a pretty good job of making sure that people have become more trauma informed. So people are more aware of post-traumatic stress disorder and acute stress reactions in children, which is great. But we have not done as well with some of the other types of reactions. And I'm going to go on to the next one, which is grief. So the crises such as the pandemic caused widespread distress among children and adults, but not all this distress represents trauma symptoms. In fact, the challenges facing most children during the pandemic, at least during the latter half, probably related more to loss than to trauma per se. Our society has grown of late to appreciate the important impact of trauma on children, and we've become trauma informed, but we've been slow to recognize that we also have to become grief sensitive. I responded to one mass shooting, and there was a teenager who was involved, and the person on either side of him was shot and killed, but he was not physically injured. He went back to school once over the next several weeks, but only stayed for a couple hours, and he had declined counseling. So I went with his permission to his home to visit him, and I asked him, why aren't you in counseling? And he said, well, they just keep wanting to talk about the shooting. I mean, he looked at me and he said, look, I had some trauma symptoms. I had difficulty sleeping. I couldn't concentrate. I was jittery. I startled easily. And he said, but after about a week, I wasn't bothering me anymore. So then I said, well, why aren't you in school? And he said, well, it didn't feel right being there without her. He was on a date that at that time of the shooting, and the person on one side of him was his girlfriend that he planned on marrying. And he said, being in school without her didn't seem right. So I looked at him, I said, well, maybe you're grieving the death of your girlfriend. And he thought about it. And then he looked surprised because no one had mentioned that. And he just said, that's it. And if someone's willing to talk with me about that, I'll go for counseling today. I just don't want to keep talking about the shooting. So the issue was he had been through a very major traumatic event, but he was really dealing with grief and loss. And the management for how we support people around grief and loss is very different than the way we try and support them after they've been through traumatic experience. At a very basic level, when we're dealing with a traumatic event in someone's life, we're helping them try and figure out how to cope with something that happened. But when we're trying to support them around grief and loss, we're helping them figure out how to deal with the ongoing absence of something important in their life. And in many ways, that's kind of an opposite. And so what we do is sometimes quite different. So as was mentioned, I was on the Sandy Hook Advisory Commission, and I coordinated the response with my center for the first week, but I was then pediatrician in chief. I was starting as pediatrician in chief at a children's hospital, and I couldn't remain. But I did stay as part of the Sandy Hook Advisory Commission and traveled back on an ongoing basis to talk about what the state could do. And in one of those meetings, a family member came and she said to the group that she got the yearbook in the spring, and when she opened it up, she discovered that the picture of her child who was killed at Sandy Hook had been removed, as had the photographs of every child and adult who died that day. And she just looked at the commission and she said, I don't know what they were thinking. It's like they never existed. Why would they do that? Well, as I said, I didn't stay involved in day-to-day activity with the schools. So I don't know what they were thinking. But I have been in other schools that have similarly removed photographs of individuals who have died tragically. And when I've asked them why they would do that, their comment has been, well, they're trauma triggers. So we're trying to remove trauma triggers. And I look at them and I go, those are not trauma triggers. Those are grief triggers. And while in trauma triggers, we do want to avoid all of them, grief triggers, sometimes we want to have grief triggers because they are ways that we demonstrate our continued love for someone that we've lost. That's why people go to cemeteries and go to funerals. It does reactivate their grief reactions, but it would be worse if they didn't remember and think about someone that they had deeply loved. So the issue is we don't deal with trauma and grief in the same way. And we have to be able to be not only trauma informed, but grief sensitive, attachment aware. There's a lot of things that we have to think about, and no one solution is going to meet all the needs of the children. If you go on to that list, the next one is guilt. People somehow manage to find reasons to feel guilty, irrespective of their actual experience or role in a crisis event. And at some level, often unconsciously, it may feel easier to feel responsible for something you did, didn't do, or should have done than to simply accept it might have nothing to do with you. Because if it had nothing to do with you, the first crisis that occurred, that means it could happen to someone else you care about, and there may be nothing you can do to prevent it. So what happens is, in order to deal with the anxiety that this might occur again, some people will adopt the illusion of control because it gives some initial reassurance. The problem is it is an illusion of control. So it doesn't really help prevent others from getting ill or sick or dying from a shooting or whatever the disaster was. And it leaves the person with guilt that impairs their adjustment. I've also seen survivor guilt, as well as guilt for not having experienced loss or trauma when others have. So it's a very common reaction. And I always make sure that I reassure children of their absence of responsibility, even when you wouldn't think there's any reason why they should feel responsible. I'll often just say to kids that when something bad happens, we feel badly. And when we feel badly, we often assume that there's something that we did that was bad. Thoughts and feelings don't cause people to die. But a lot of kids tell me somehow they feel that they were responsible. Have you ever felt that way? Even that comment, and I do that with adults as well. I will reassure parents of their lack of responsibility because, again, they often feel that way. I think Calvin explains it best. He calls for his mom and he says, a big dog knocked me down and he stole Hobbs. I tried to catch him, but I couldn't, and now I've lost my best friend. And his mother says, well, Calvin, if you wouldn't drag that tiger everywhere, things like this wouldn't happen. And he points out, there's no problem so awful you can't add some guilt to it and make it even worse. So whenever there's a crisis event, we really do need to reassure individuals of their lack of responsibility. Now, a lot of times kids will, these reactions are very common, but they're not just due to the crisis itself. It may actually be due to a wide range of other stressors associated with a particular crisis event. So I remember in one of my visits to New Orleans, I was talking with an educator, and she said that she was actually quite lucky. Her apartment was not damaged, and she was able to stay in her apartment because she was living in the French Quarter, and it was above the waterline. And so she said she was lucky for about 3 or 4 months, and then her lease ran out, and her landlord doubled the rent. She could no longer afford that. So as a result, she had to move, but there wasn't affordable housing nearby. That's why her rent doubled. So she said, I had to move about 45 minutes away, and functionally now I live out of the trunk of my car. She said, but the real problem was I had to remove my daughter from high school in New Orleans and relocate her about an hour away. her daughter became depressed. She ended up in an emergency department, got started on some antidepressants, but they couldn't access counseling. I don't remember the reason why. So someone suggested a pet. Maybe if they got a dog, that would bring her some comfort. So she got a dog, and the dog attacked someone in the throat. And the teacher looked at me and she said, I'm going to trial next week, and my attorney says there's a very good chance I will be bankrupt after this. So she did not have post-traumatic reactions to the hurricane, but her life was very much disrupted by what had happened. We're seeing this play out in the pandemic recovery. There are things that happen after crisis events. There's these cascade of losses and stressors that occur. So individuals don't just react to what happened on the particular day of the crisis event, it's anything that followed. And then to make it even more complicated, one crisis can awaken feelings related to pre-existing or even past crisis that wasn't fully resolved. And that may assume a primary focus for a particular child or adult. And that may be even if the prior event was unrelated. I went to one school that had a shooting where one child was killed. And I did a presentation for the staff after school. And when I came back the next morning, the principal greeted me at the door and she said, you got to talk to one of these teachers. She's been crying ever since you spoke. And so I went to talk with her. And what she explained to me was she wasn't in school on the day the shooting occurred. And she had never actually met the student. And she couldn't understand why she was so upset. She was having trouble sleeping and concentrating. This had been several weeks. And she said, as soon as you made that point that it might have uncovered something prior in people's lives, I realized my brother was murdered 10 years ago to the day this child died. She said, I didn't even make the connection. I wasn't grieving the kid that I never met. I was grieving the death of my brother. And she said, I always had anniversary reactions, but they only lasted a day. But I got stuck on this one. And then you made the association and I realized that's why I was stuck. So she came back to thank me because she said, now I'm good for another year. So the issue is you may, when you respond to a crisis in a family's life, you're not just responding to a crisis, you're responding to everything that occurred beforehand and everything that occurred afterwards. And it gets very complicated. So you would think everyone would be upset and everyone would know that, but actually we tend to underestimate the extent of children's reactions to a crisis, especially related to their internalizing symptoms, how they feel. If we do a good job, we may be able to observe how they act, but we can't observe how they feel. They have to tell us. That's why these posters that were put up by Project Liberty in New York City after 9/11, they all had the same tagline, if only the signs were this easy to read. But children may attempt to withhold their complaints of these symptoms because of concerns they're abnormal or at least inappropriate, or because they're trying to protect their parents or other adults who are visibly upset. School and community shootings may also impact children who have no direct ties to the victims or the community where the violence occurred. When something tragic occurs outside of our usual impact, like it's not where we live, it's not people we know, we hear about it, and it still is upsetting. In the bereavement field, we call this a threat to the assumptive world. We have many assumptions that allow us to get up in the morning and go through our day without being overwhelmed by everything that could happen. But then something happens. People go to see fireworks. On the 4th of July, we were at fireworks. Someone is shot at the fireworks and we realize, wait, you could be injured if you go out in public. Well, yes, there are lots of guns around and yes, people do discharge them and sometimes people die. You would think if you're at a family event, celebrating the 4th of July, it should be safe, but that's an assumption. And as soon as that assumption is violated, you start to question all the other assumptions that you made. And that's what we call the threat to the assumptive world. And that's why we can be impacted by something that happens across the world, just because it reminds us that it could happen to those we care about or to ourselves as well. Now, as we start to think about recovery, from these events, I want to spend a little time talking about the time course for recovery. So life-changing events, such as major tragedies, do exactly that. They change who you are as a person and they change your life. So you don't get over them, but you do move beyond them. So here is a kind of a graph of adjustment over time. It's not a straight line. We have times where we're doing better, and then we have times when we're in distress. Because of all the attention to trauma, people have started to see any type of distress and refer to it as trauma. But really, it can be just distress. and individuals do have distressing experiences. And so if you see somebody who seems to be doing poorer than they did before, they're not necessarily in crisis. They may be just distressed, and they will generally recover from that. It's interesting that crisis events are actually not defined by the events themselves. They're defined by the individual or system's capacity to recover from the event in the absence of external support. So when someone or system is resilient, it means it has the capacity to recover. It doesn't mean that it isn't upsetting. So if we are professionals and we are experiencing distress from an event, we should access and accept help. We should offer help to others, even if we know they're resilient and we know that they'll be able to recover. They can have the same amount of distress and they still deserve our attention and support. But let's say that a crisis event has occurred and now you have exceeded the person's capacity. Then at point C, they're in a vulnerable state, and by point D, their usual coping mechanisms have failed. In most situations, people come to help. There was a problem with the pandemic. There was no cavalry. There was no one who wasn't infected who could come in and help. So let's put aside the pandemic, but usually people do come. Generally, they bring money, they bring resources, they bring social cohesion, they bring food. Some people start to improve. This has been called the honeymoon phase. I actually have, because that's what we do when people get married. We bring food, money, and we socialize. The problem is that I don't call it the honeymoon phase because it suggests to some people that marriage is a disaster, and that resonates too much with people. There is a whole issue about languaging and how we talk about in the words that we use for crisis events. So I don't actually refer to it as a honeymoon phase. It is a period of improvement. But at point E is when people feel most helpless and hopeless. So this is generally more with adults after natural disasters, is that after some time has passed, weeks to months, individuals will increase their risk of self-harm. So if people recalled after Katrina, about 3 to 4 months afterwards, I would visit New Orleans, and people in healthcare could tell me about the number of people they knew in the healthcare field who had killed themselves since Katrina. There actually was a supplement to pediatrics, the Academy's publication, that was dedicated to a young pediatrician who killed himself after Katrina. So that is the most vulnerable time. We are in that time period now. It's where people look around and think we are back to normal, but they don't feel back to normal. People hide their distress. It looks, everything's open, restaurants are open, people are traveling, people are back at work, and you start to think, I should be back to normal now, and I don't feel that way. And so that's the most vulnerable time period. So we really have to continue to provide support to children and adults until they've at least reached their baseline. Because if we withdraw the support too soon, most people will not harm themselves physically, but they may not get back to their baseline and just establish a new baseline that I called continued impairment. We have to help them until they return back to their baseline for however long that takes. And I think for the pandemic, it will be not just months, but probably years. And for some individuals, not the majority, but for some individuals, if they have sufficient support and enough internal resiliency, they may actually exceed their baseline. We call that post-traumatic growth. And in post-traumatic growth, individuals may actually exceed their level of coping. They may have a better sense of spirituality, a commitment to help others, more empathy. And what you will find is sometimes people, as a result of disaster and crisis, go into helping professions. So I did one presentations to a group of foster parents after a large natural disaster. And one dad raised his hand and he said, I think that was me. So his story was that he had worked on Wall Street in finance. He was very successful. He was young. He was happily married. He had a toddler. He thought his life was great. And then his toddler got sick and died from an infection. He said, I then started to question everything about my life. And he said, look, I made a lot of money on Wall Street, but I started to think, am I really changing the world and the work that I do? And he said, no. I was making money for rich people and thereby making money for myself, but I wasn't making the world a better place. And he said, I realized I didn't have a career, I had a job. So he said, I quit my job, even though I was successful, and I went back to college to become a kindergarten teacher, because changing the lives of a young child, that's a career, that's worthwhile. Felt like saying, dude, you do know the financial difference in earning potential, hopefully, but I'm sure he figured that out. So the issue is that people go into child care, early education, education of all levels, medicine, pediatrics, and mental health, often because of something that happened in their childhood or the childhood of someone they care about. Someone helped them or someone didn't give them the help that they needed. And they've decided to devote their career to helping others. The reason I go through that is that when a crisis occurs, you uncover past feelings related to crisis events. So the irony is that individuals in helping profession are most likely to be hurt by helping others. And that's why I just wanted to end talking about the importance of professionals' care and self-care. We are at more risk than the general population of being impacted by helping children, which is what we do for our career. And we need to recognize it's distressing to be with people in general and children in particular who are also in distress. And it's important that professionals appreciate and address the impact of supporting children who are grieving or traumatized as it's happening on them personally and professionally. And we need to create a culture where, frankly, it's just okay at times to be upset when upsetting things happen, and when everyone looks out for each other and normalizes asking for help and models a willingness to accept assistance. You have to find ways to take care of your colleagues and take care of yourself. Now, exposure to the trauma and suffering of others can lead to what's called compassion fatigue. Empathy involves understanding and taking the perspective of another person, but compassion goes further. It requires empathy, but it includes the additional step of wanting to help and or desiring to relieve the suffering of another. The word compassion has two Latin roots, which mean to bear or suffer together. And it's that element of shared suffering that's coupled with warnings about compassion fatigue. It tends to imply that compassion is necessarily tiring or exhausting. Like we're born with a fixed amount of compassion and we're going to run out if we care too much or care about too many people. But that's not the case. Compassionate approaches actually can be gratifying and bring meaning to the work we do, and therefore decrease burnout, not increase it. But that's really only likely to occur when we have realistic objectives of what we can do. So if you're trying to help someone in a disaster, you're not trying to make them feel happy. You're trying to help them begin to cope with something that's very upsetting. And this is you have to feel that you have the skills and the resources to provide meaningful assistance. And that's really hard when you're in an austere environment, such as after a natural disaster, and you have your own personal and family challenges. You have to be allowed and empowered to provide the support to families, and you have to still be aware of and have sufficient support to deal with the personal impact of the work. Compassion does require more emotional effort, but just like physical exercise, when you first start an exercise program, it's tiring, but ultimately you increase your capacity for physical activity, and it's ultimately energizing. And as I said, the capacity to provide compassionate care increases with practice, and compassionate approaches can be gratifying and bring meaning to the work you do and decrease burnout. You also have to realize that hearing the trauma stories of individuals impacted by crisis events, when we are compassionate, can transmit some of the trauma to the helper, and that we refer to as vicarious traumatization. Healthcare providers should appreciate their role is to be supportive and help children and adults connect with professionals that can help them process the trauma and loss they've experienced. But it isn't necessary for you to listen to their full stories in order to do that. Just listen enough so that you know how to guide them to help. And the last slide is just going to go over some website resources where you can find more free information. That might be at the National Center for School Crisis and Bereavement's website, schoolcrisiscenter.org. Through the Coalition to Support Grieving Students, the American Academy of Pediatrics is a member of the coalition, for example, as are over 135 organizations. You can go to grievingstudents.org and find a wide range of both print and video-based materials on how to support grieving children. And then the American Academy of Pediatrics has a Children and Disasters webpage, and one particularly on coping and adjustment. So I'm going to end there, and I don't know if you want to ask any questions, but
yeah, I wanted to thank you, and I am just, your compassion is just so admirable, because every story you told, I wanted to cry, and you must have such great resilience to be doing all the amazing things that you're doing. Really appreciate you. Every time I listen to you here and nationally, like, I just learned so much. I wanted to actually ask if our audience has any questions. If you want to raise your hand or put it in the chat, please feel free to do so before I ask my question. because I can always ask that. Okay, so I am going to go ahead. I have a couple of questions. We'll see how much we have time for, because I know it is 1 o'clock and you probably have other meetings you have to be at. But just really quickly, if you don't mind just telling us, since pediatricians only spend a few minutes in the clinic with the child, are there a couple of questions or things that they can ask that might help them determine which children, since most of them aren't going to show symptoms, but which children might need to be referred versus which ones that can continue to be monitored or just need additional kind of support that the family or they can provide?
Yeah, sure. I gave a story about New Orleans and that educator to show you that, because I remember going to a community that had wildfires and talking to a group of pediatricians, and they said, every time families come in, we ask them if their house burned. And I go, yeah, you certainly can ask that, but they may be having problems because their babysitter's house burned and now the kid never sees their babysitter again, or they had to physically relocate it. Actually, there was one study done after Hurricane Maria in Puerto Rico, and they found that the majority of children had suffered significant losses, but they weren't because of the hurricane most of the time. It was because of permanent relocation of people off the island. So what happens is you really should ask more general questions, such as, I know this has been a difficult time for our community. How are you doing? And have you had any difficulties that you're willing to share? So you want to let people know that they can talk with you about what's upsetting. Again, you don't have the time to go over it or to provide that counseling. You're really there to provide emotional support and to get them to the right people who can help them. Now, the issue is I always avoid asking people if they think they need counseling, because it really isn't about whether or not they need it. It's whether they might benefit from it. So if they would benefit from someone providing support, then we should offer that to them. But what you'll see a lot of times, people say, well, I don't really need it, or I don't really deserve it because I don't know anyone that died. I have found people will always say that there are people worse off than them. I went to one mass shooting and a family said we should consider ourselves lucky. We only had one child that was murdered. I know a family that had 2. And I was like, one's enough. You are willing to, you should be able to accept support for that. You will always, there's always people doing worse. But if we can be helped by talking with someone or providing or receiving support, then we should certainly access it. So I think I would ask general questions. How are you doing? Has there been any changes that you've noticed for yourself or family members? Or sometimes for kids, I like to ask, how are your friends doing? Have you noticed some people seem really deeply affected by this? Others aren't having as much trouble. What are some of the things you're hearing from your friends? And then I might say, and are you finding any of these for yourself in terms of reactions? That's the way I would approach it.
I like that. Sounds like a safe way for children to be able to respond. And then do you have a second I can ask you an additional question, Dr. Schonfeld? Yeah. So is there any way to prepare children so that they have better mental health pre-crisis? Like, is there anything that we do our disaster preparedness, family preparedness, but like is there anything specific that you would recommend that anticipatory guidance that we can give families to help their children be able to respond better in any disaster?
Yeah, when we look at risk factors for adjustment difficulties, it includes such things as lack of good communication with parents, when parents are not coping well, pre-existing mental health problems, concurrent stresses that are occurring in their life, the issues around poverty and racial inequity. So we know that all of those set kids up to have more difficulties with coping. And we also know that if we give them more coping skills, like if they learn different strategies for managing how they feel and how they cope with things, they will be better able to deal with crisis events. So I guess the answer is, and it's a good strategy, let's just make kids as healthy as possible emotionally and give them the resources and the coping skills they need. And if they don't have a crisis, they'll just be healthier and happier, which is not a bad thing. It's a wonderful investment. So all of what we do with anticipatory guidance and general pediatrics, let's just do it really well. And that will place kids in a better situation. Now, we can take some steps to help them prepare for specific types of disasters. So if you're in a community that's prone to flooding or wildfires, help them think about what would happen if something like that did occur again in their community or for the first time, and help them think about what would I want to be able to take with me? What's important for me to be able to cope with something like that, and get them ready for it without putting them through drills or exercises that are emotionally upsetting. But let's get them ready so that they have some sense that, if there are wildfires and they need to relocate, in the vast majority of cases, you have time to do that safely. So let's let them know that we would have time to do that. And this is how we would do it. And you've helped prepare for that. But then people start asking me, well, what about mass shootings? What can you do to prepare them for that? And I would say, horribly tragic events that are extremely frightening, they are going to be upsetting. And so we can't prepare people for that to the point it won't be distressing. So I'm more talking about preparing for manageable crisis events that allow them to have some sense of control and can allow them to shape how they do respond. But being prepared for sniper fire when they're out at the grocery store or something like that, I don't think there really is a way to prepare for that other than that more general mental health that I referred to.
Wanted to thank you again so much for being here. And I love listening to you every time. For our AAP members, we will email you with registration. We have the tabletop coming up next week. It'll be either, again, the 12th or the 13th evening, and we'll email you. It'll be virtual, so it'll be easier to attend and with that information. So please register as soon as you get that. And then we will just look out for the scavenger hunt that you'll be getting in the mail, and that'll be one per practice. There'll be, we have some incentives to complete that, and the responses we'll get will be collated and actually built upon to make a repository for all of the members on our website. So thank you again for supporting children in the community. And we look forward to seeing you at the tabletop. Thank you, Dr. Schonfeld.
Thank you. Bye-bye.